All right. Well, I think we're going to go ahead and get started with our last session of the day here. So we are very excited to have our own Dr. Caitlin Getty here to follow up on some of the wonderful critical care discussions we just had. We're going to have a little bit more in-depth discussion on how we can think about critical care nutrition for our patients. So Dr. Getty is a board-certified veterinary nutritionist with special interest in critical care nutrition, convenient, and as well as everything cats and teaching. She spent 13 years at the University of Illinois, completing her bachelor's, DVM, and a PhD in nutritional science. So she bleeds very dark blue and orange. And during veterinary school and her PhD, she became very interested in nutrition education of veterinary students and the power of nutrition in health and disease. She then completed a rotating internship in small animal medicine and surgery at Premier Veterinary Group on the north side of Chicago, and then went to NC State to complete her clinical nutrition residency. There, she really developed her love of critical care nutrition and was fortunate enough to be very involved in the education of third and fourth year veterinary students. And then she started her career in the fresh pet food space, but we are very fortunate to have her now here as part of our Hills group. And so we're excited to have you here, Caitlin. And with that, I'll hand it over to you.
Thank you very much, Dr. Hull. And can you guys all hear me okay with this mic? Looks pretty decent. I feel like I can hear myself. Perfect. Thank you very much for the thumbs up. That's helpful. So I just put a little about me here with all the places I've been, but also I wanted to highlight my pets, which I'll show off a little bit later too. I've got my 3 cats and then my 3 bonus animals, so I just wanted to put them here. All right. So today we're going to talk about critical care nutrition, and I've titled this talk, Don't Forget the Groceries, the importance of critical care, or the importance of nutrition support in critically ill patients, because as we've hinted at today, nutrition, everyone needs to eat. Nutrition is very, very important. Okay, so we're going to talk a little bit about the nutritional assessment, kind of go back over some of the things that Dr. Nascimento and Dr. Viduva covered, a little bit about metabolism in our critically ill patients, talk about the nutrients of concern and the things we want to look for in our diets for our patients, and then also a little bit about how to develop a nutrition support plan, things we want to look out for, and then of course we'll have some questions at the end. And this is Connor. He's the favorite child, but he was trying to do like a little Halloween thing. This was like a month ago for some reason. Okay, so the nutritional assessment. This is something that we need to do for every patient every time. I know we talked earlier about how time is difficult. Getting to do all of these things for every patient all the time is challenging, but it's super, super important to do a nutritional assessment in every patient every time. And in our critically ill patients, that's even more important. Maybe multiple times a day we're doing a nutritional assessment, right? We want to know the history. We want to know the medical history, what's going on with our patient. We want to find out the nutrition history. So those diet history forms. What has the animal been eating? What do they like? What do they not like? Are they picky eaters? Things like that. Of course, our full physical examination, including our BCS and MMI, which we'll go over in a little bit more. Our quantitative things, so like our CBC chems, and then lastly, formulating a nutrition support plan. But the thing to remember here is that this is an iterative process. So we go through it once, but then we're always going to be going back to the beginning and reassessing our plan and making sure that it's still appropriate for our patient. So the diet history. So this is the form that's found on the AHA website that we put together in collaboration with them. So it's a nutritional pre-screening form. Now this is more something generally for your probably more healthy patients, but it could be used in your critical patients as well if your owners have a little bit of time, once you've gotten the pet stabilized or they're hospitalized or something like that. But, to really let them know, to really let them take it home or go through what they have in the hospital or in the house to see what the animal's been eating. So, maybe they're eating the food and it's got the green label and I don't really know what it is, but having this form and being able to go through it, they can go find the food, write down what it actually is and how much they're actually feeding. And so along with the diet history, right, we're talking about the different foods they're eating, how much, but there's more to it than just what food and how much. It's, do they like the food? Are they going to the food and, maybe sniffing around and eating a little bit and then walking away? Different than grazing, right? Maybe they're disinterested in the food, or maybe they're not liking it at all anymore. So are they anorexic, where they're not eating any food? Are they hyperexic, which is one of those words that's kind of been defined a couple different ways, but is it, like a partial anorexia where they're not eating to their RER? Or are they eating more than they're usually eating? So do we have something like a diabetic that's eating more than they're supposed to be eating? And then also things like, do we have weight changes that we've noticed? Do we have changes in the body condition score? Have you noticed a loss in muscle mass index? And then just putting that all together to help better assess our patient. So body condition scoring, Dr. Nascimento did a very good job going through this earlier. I've put the WSAVA body condition scoring chart back up here for your reference. But again, the 4 to 5 for both cats and dogs is going to be considered our ideal body index. And in our critical, so we were talking about obesity before. Now we're talking more about our critical care patients. So we're thinking probably more along the lines of those underweight, but they could be their ideal weight. Or it's really important to remember that obesity is also a form of malnutrition. So no matter where they fall on that scale, it's really important to know, to come up with an ideal plan for them and know what exactly is going on. And then muscle loss. So we'll have the muscle mass index again on the next slide. But in our critical patients, in our senior patients, in our cancer patients, maybe in our cardiac patients, right, we start to see this muscle loss. And is it from something like they have not been eating enough? Is it something like a disease process? Is it something associated with maybe old age? And so there's a couple of different kinds of muscle loss that we might see. So cachexia is the one we think about in terms of, cancer or cardiac disease or prolonged illness. So we've got a loss of muscle and adipose tissue as a result of the ongoing stress or disease process, which is different from sarcopenia in our old patients where they're otherwise healthy, but we have this age-related loss of muscle mass and some adipose tissue as well. So muscle condition score, muscle mass index, you might see either of those terms used relatively interchangeably. I've got the dog and the cat one here. So you might see in some records, it's a 0 to 3 or 3 to 0 scale depending on where you are. So this is the WSAVA. You can go on the website and find these. There's a whole chart about how to use them. But sometimes you might see that an animal is a 0 out of 3, and that means that they're severely muscle wasted. Or some people use a 0 out of 3 to say they have completely normal muscle mass, which is a little bit confusing because it hasn't totally been standardized in that way. And so what I like to recommend is that if you're noticing anything, or even if they're normal, to put that in that musculoskeletal part of your assessment so that the next person or even you the next time knows what that meant. So maybe like institution to institution, you're saying this animal's a 3 out of 3, it's perfectly normal. Someone else is like, what, 3 out of 3? Like, it's super muscle. And you're like, no, it's totally normal. So putting in that in the medical record what's going on. Or maybe you notice a localized muscle loss. So maybe you notice that they've got muscle loss, over their skull or over their back, or maybe their hind limbs. You want to put that in the medical record as well to help tell us what's going on and help you reassess your patient at every time. And so with the muscle mass index, it's a tactile thing. So some of it is visual and some of it is tactile. And there's a couple of different places that you want to evaluate your patient. So, over the top of the head, over their apaxial muscles, those hind limb muscles as well. And you're going to kind of look, put your hands, like for the back, for example, you're going to put your hands over the animal and, your fingers are going to meet over those dorsal spinous processes. And if it's a nice, round muscle feeling, that's going to be a normal muscle mass index. But if you start getting things like this where, the muscle is kind of going up over the dorsal spinous process, that's where we're starting to see loss of muscle. And really, if you can do this, then we're probably getting down more into the, moderate muscle loss and things like that. So really putting your hands on the patient to know what's going on is super important. And so we know that in hospitalized patients, depending on how long they've been hospitalized, if they're not eating, or even if they're not eating enough, they're probably going to lose some body mass. But we don't always see it. So I've got a couple studies. This one came out fairly recently. This is 2018, so within the last 5 years, where they looked at the evaluation of the prevalence of risk factors for undernutrition in hospitalized dogs. And you could see that in this figure over here on the left, I always have to do that all the time. I even have to do that when the animals are live in front of me. I'm like, okay, where are we at? You can see that these animals, the longer they're hospitalized, a lot of times they're not necessarily eating as much as they're supposed to, or if they're not eating as much, that BCS is going down. And then you can see in this table here the different risk factors for changes in body weight, body condition, and kind of the outcome of these patients. The length of time they're hospitalized, how much they're eating, if they have vomiting, things like that were all prognostic indicators for if they're going to lose body condition and body weight. And then this is just another one. This one came out, I want to say within the past year, but this is loss of body weight and lean mass in long stay hospitalized canine patients. So this was a 60-day study. This was in New Zealand. And it was a relatively small study of the animals they actually could evaluate, but you can see that the length of hospitalization correlated with the decrease in body weight. So we know that the longer in hospital, they're not eating as much, they're going to start losing body weight. And actually, interestingly, a lot of these dogs were the ones that were hospitalized long-term for things like neurologic disease, right? So they're hospitalized a long time, they're not getting up, moving, things like that. Okay, so now we've assessed our patient, we've done our physical exam, we've done body condition scoring, muscle mass index, nutritional history, and things like that. We still want a quantitative evaluation, right? So we've talked about today are doing our CBC chems, UAs, don't forget the urinalysis. I'm sure you've heard that like a million times, but it's very, very important. We're looking for things like glucose, protein, white blood cells in the urine. If you do have protein, a UPC, because that's really gonna influence what kind of diet we're gonna choose for our patient. Like was mentioned before, we want to look at the thyroid, see what that's doing. But in our ill patients, we could have euthyroid 6, so it's a little bit different. Ionized calcium, if that's something we're looking at. Remember, total calcium is not always the best indicator of what's actually going on with calcium. And then things like imaging, so our radiographs, ultrasound, POCUS, which is great. TAMU GI panel, so the folate, the B12, our pancreatic markers, and then others depending on the case as well. Okay, so this is a chart out of, it was an article in Vet Clinics of North America Small Animal Practice from 2020, and it was about nutritional support in our critical patients. And this is just a chart that kind of puts into a scoring system, I guess, of how at risk is your patient. So it takes into account things like, have they not been eating for, however many days? So this is less than 3, 3 to 5, or greater than 3. And they're saying less than 80% of their RER. So, they're basically anorectic at that point. Have they lost weight? Do they have vomiting and diarrhea? So maybe they're eating, but they're not absorbing anything and it's coming out the other side, or they're eating and they're vomiting and they're not absorbing anything. Is their body condition score less than a 4? So are they underweight? Muscle mass, do we have any muscle loss? If they're hypoalbuminemic, that is also a negative prognostic indicator. And then how long do we think they're going to be sick? Because it's a little bit different if you've got a dog in for a TPLO, they're otherwise healthy, but they're going to be hospitalized for a day or two while they get the feeling back in their leg and they can walk, and maybe they'll eat when they go home, versus a patient that we think is going to be in the hospital for a week or two. It's going to be having bandage changes. It's going to be sedated and anesthetized. We don't know if it's going to eat. Maybe it's going to be fasted and it's not going to eat. So that's why, having an idea of what the disease course or the treatment course is for your patient is really important. And so depending on how many of these we have, can kind of help us decide how at risk for malnutrition or in need of nutritional support these patients are going to be. So then just a little bit about the metabolism of critical illness. So how do we know what animals are metabolizing, right? We can talk about, they're only using protein or only using fat, but how do we know that? And so we've done many years ago, they've done indirect calorimetry to show that with the respiratory quotient, so how much carbon dioxide is produced to how much is, that should say used, but that's okay. And we can look at what they're actually metabolizing. So fat, if they're metabolizing primarily fat, we're gonna have a lower RQ of 0.7, protein is 0.8, and then carbohydrates are gonna be right at 1. And so something mixed, if they're utilizing all of them, is gonna be somewhere more like 0.8 or 0.9. But if we're starting to get down closer to the straight 0.8, 0.7, then we know that the animal is using fat and protein for energy rather than carbohydrates from the diet or the ability of the animal to make carbohydrates on its own. And so in simple starvation, so the animal is just not eating, or for some reason hasn't been fed or doesn't have access to food, but is otherwise relatively healthy. This is a chart out of the Small Animal Clinical Nutrition book. I'm sure you guys have all seen the big blue nutrition book. But this shows us what is being used and produced by the organs up to 10 days of starvation. And so you can see that we're going to be having more lactate and pyruvate and what the kidneys and livers are using, and we're using up that glycogen. And so we're going to have to start going to amino acids as well as fat as an energy source as we progress. And as it goes on, so this first one here on the left, so you can see this is in weeks, so the previous one was in days. You can see that of the stored energy sources, right? So our adipose tissue, our skeletal muscle, which we don't want to use it for energy, but it can be broken down for energy. And then also things like our glycogen, so that carbohydrate storage. You can see after just a couple days, all the way on the side, the carbohydrates are basically gone, and the animal has shifted to using protein and fat. Ideally, they're going to use their fat stores before they start using their protein stores, which is, you can see that fat is more drastic than the protein, but eventually they're going to start breaking all of that down, and that's when we start getting the lean muscle loss, the adipose loss, the weight loss, and these patients become very, very critical. And then the next chart, these are also both from the Small Animal Clinical Nutrition. This is, where's the glucose coming from and where's the energy coming from? So again, exogenous glucose, so that dietary glucose, that's gone in 4 hours. Then we're going to start using, the liver is going to try to make glucose. It's going to break down glycogen. It's going to make glucose. That's those blue lines. It's going to be gone. Within maybe a day and a half is really when that's going to start changing over to using other things to make glucose, so that gluconeogenesis. And then you're going to notice that ketosis start to go up because we're using fat as an energy source now. So if we don't have food and we're losing all of this protein and we're using protein for energy, that's going to start affecting other things as well. So, you think about our sick patients, maybe they're in for some kind of illness, maybe, they're just in for an injury or something like that. But if we don't have enough protein intake, our immune system's not going to function nearly as well. So we need protein to make cytokines. Antibody affinity is protein's necessary for that as well. And then for our white blood cells to function and our immune cells to function, we need protein. GI permeability, which we'll talk about a little bit more on the next slide, but that starts to increase, which is not great. And then that gastrointestinal associated lymphoid tissue is not functioning as well. We know that that is highly responsive to feeding, so if you can feed that animal, that will improve. And actually, in a study in rats, so this is this last little thing in here, if you only provide electrolytes, they don't make enough globulins and they don't have as much immune function. But if you start to feed them food, then they actually start to have an improved immune response. So what happens if we don't feed the gut? This is the whole use it or lose it phenomenon, right? So the small intestine is really, really sensitive to not being fed. It's getting some of its nutrients from the food, right, within the lumen. And so within 3 days, so really, really fast, we can start seeing changes in the structure of the small intestine. We see atrophy of the mucosa, impaired intestinal permeability. So we've got those tight junctions that are trying to keep things out. But if we don't have a good, if we have impaired permeability, right, those start to get loose. And that's when we start to see things like bacteria translocating, endotoxins translocating, and start to see things like sepsis from impairment of the GI immune system there. And then that can also lead to the immunosuppression again in that GALT. We get reduced absorptive area. So now that we haven't fed the gut and we want to feed the gut and we want it to do things, well, now it's not going to be as effective because we've had that mucosal atrophy, and so it's not going to absorb things as well. So it's going to take some time to get back up to fighting shape. And then with that too, we're going to have reduced digestive enzyme activity because, right, some of those live in that brush border and those are going to be affected as well. And we know that these changes aren't reversed by parenteral nutrition, right, because that's IV, that's not going to the gut. And so we have to try to prevent this with early, like was mentioned before, enteral feeding to try to support that GI tract. So in addition to the GI tract, which is my favorite, Even if we have like the TPLO, for example, we need to feed the animal to have tissue synthesis and repair for that surgery to be successful. So wound healing, collagen synthesis, that requires protein, that requires vitamin C. If we have, not enough protein, again, protein's one of the big ones here, but we're gonna have a negative nitrogen balance. We're not gonna make all of these things that we need to. And then there's lots of other nutrients that are involved in the healing and metabolism within the animal. So it's really everything that we have to consider. And then other things, so maybe we're not necessarily super worried about healing, maybe that's in the back of our mind. Well, drug metabolism is also affected. So if we have protein deficiencies, we're not gonna be able to carry drugs as well. We're not gonna have as good of cytochrome P450 clearance, and so that's gonna affect drug clearance. So maybe the drug that you thought would be out of the animal system in 8 hours is gonna take 12 hours, something like that. Hepatic biotransformations, so you give a drug, it's the inactive form, it needs to be transformed by the liver in order to work. Well, maybe that's going to be impaired as well, and that drug's not going to be as effective as you wanted it to be. Again, transporting drugs, binding drugs, and then protein. If you're not getting enough protein, we're going to have decreased renal blood flow. Maybe this medication is excreted in the urine, and that's not going to be as effective as well. So it's also proper nutrition. Getting that animal supported is going to be really, really important for drug metabolism, in addition to all of the other things. And so malnutrition is unfortunately really, really common in our hospitalized patients. So in human medicine, 25 to 50% of patients were considered malnourished. In veterinary medicine, it's an estimate. It's like 25 to 60, so fairly similar to the human hospital world, but we just don't have nearly as much data. In animals, there's a whole Aspen and JPEN, there's whole societies dedicated to nutrition and assisted feeding and things like that in the human world. We have some of that in smaller fractions in the veterinary world, but it is much, much smaller, and so much more research is needed to be done. But we can draw a lot of information from the human world. And then a study in 2018, so this was in Frontiers, it was 489 dogs, so almost 500 over a 9-month period. Of those, 96% of those dogs didn't meet RER while they were in the hospital. So either they weren't eating or they were only eating a fraction of their RER. And so to be able to support themselves, that's not quite enough. And 84% of those were consuming less than 25% of their RER. So not even 25% of their DER, 25% of their RER. And despite that, which is interesting, most of these dogs actually maintain BCS. So while it is important to get a body condition score and monitor that regularly, that's not going to be the best indicator of how the patient is doing in terms of their nutrition. It's just more, at least at the beginning, a good starting point to know where they're starting and what we need to do to help them. So, nutrients of concern, I also call them key nutritional factors. Apologies if I kind of go back and forth, it just depends on the lingo, but NOCs tended to be easier for me to say. So this is a graph, and it's kind of our 6 classes of nutrients. So we've got our protein, fat, carbs, water, vitamins, and minerals, right? So our six nutrients, all of them basically are important for any patient, but especially so for our animals that are recovering from severe illness, injury, things like that. And then also our cats and our dogs. So those are gonna be different. So cats, remember, are obligate carnivores. They're pretty much always in a state of gluconeogenesis. So their needs for protein and fat are gonna be much higher, at least initially, and throughout than a dog. They have higher protein requirements. Remember, they have an absolute arginine requirement as opposed to the dog where it's kind of a conditionally essential. They have that requirement for taurine, a little bit differences in B vitamin metabolism, and then a little bit difference in their complications, things with like NG tubes having irritation that dogs might not see as much of, or they're much more prone to obviously hepatic lipidosis if they're not fed, that we're not really necessarily as worried about in our dogs at all. And then in the dog, and this is a little bit different, this isn't really metabolism, but depending on the size of dog, and if you're doing assisted feeding or something like that, bless you, the volume and the expense might be something that you have to consider when you're working up a nutrition plan and talking to the patient and working up an estimate and things like that. So this chart is in your notes. This is kind of a general high, medium, low chart. There's really no consensus, but this is kind of what is represented across several different resources, and very similar to what I used when I was a resident. So dogs and cats are a little bit different. These are on grams per 100 kcal. So this is not percent dry matter. This is not percent as fed. Remember, this is going to be, so as fed, right, that has the water in it. We know that we can't compare as fed to as fed. Dry fed or dry matter, we know we can compare, but that doesn't really take into account what the animal's eating and how many calories and what nutrients they're getting out of it, right? Because that also includes things like fiber and ash. So animals are eating calories, and so this is based on our 100 calories. Some people put it on a megacal, which would be 1,000 calories. But these are kind of my general reference points when I'm trying to say, I think this dog should have medium level of protein, or I think this cat should have low carb, something like that. So how much protein do we want to feed the patient? And really, it kind of depends. If we have I use the term general, but no case really is that general. Our post-ops, our wound healings, hepatic lipidosis, if they're really, really inflamed, because remember, inflammation, immune competence needs that protein, is going to be high protein. But what if we have something like renal disease? Depending on the state, maybe we need more like a moderate protein, or maybe they're super proteinuric and we need a low protein, and we need to look at what the source of that protein is, which is back to where that UPC comes into play. Hepatic disease, what kind of liver disease do they have? Are they encephalopathic, in which case we want to reduce their protein to a level that they can tolerate? Or do they have more of a chronic liver disease where they can tolerate more of a moderate protein level? Or do they have something like hepatocutaneous syndrome, where now we have to give them lots of protein to help support that disease? So it really depends on what's going on. Growth, they have a higher requirement. And then things like the type of protein also matter. So plant versus animal protein, generally speaking, animal protein is going to be more highly digestible, but we have diets that have things like hydrolyzed soy protein in them, which are very, very digestible. Or maybe you have an animal that can't, maybe has some kind of urate stones, and you want a low urate or low purine diet. Intact or hydrolyzed, you have an IBD patient. And then important to remember as well is that intact proteins require digestion in order to be absorbed. And so if you have impaired functioning of the GI tract or the pancreas or something like that, maybe the protein can't be broken down as well. And so we need something either hydrolyzed or super, super highly digestible to help that patient out. And then kind of our specific amino acids, and I've got a picture of a cat here because we've got the taurine and the arginine that we want to remember. Remember that taurine is essential in cats, conditionally essential in dogs. There's a couple of dog breeds, right, that have metabolic issues where they're not using the taurine, or they're not using the glycine to make the bile acids. Usually most species or both species prefer to use taurine, but cats need the taurine to conjugate those bile acids. Arginine, always essential in cats, right? If we have a low arginine diet, that can lead to impaired urea cycle functioning. If we have an arginine devoid diet, that can kill a cat. So we want to make sure that these diets are sufficient in arginine. And that is also can be useful for dogs as well, because it is vasoactive. It does enhance the immune system. And depending on the study and depending on the disease process, you might look for something that might be arginine supplemented for those patients. And then glutamine usually is not considered an essential amino acid, but it's conditionally essential. So it is actually an energy source for some immune cells and enterocytes. So that can be very, very helpful. And then it is important for transporting nitrogen from the skeletal muscle. And then lastly, branched chain amino acids, or those BCAAs that are leucine, isoleucine, and valine. Those are important for muscle anabolism, right? Because we want them to support or build that muscle. We're not really worried about building it, but we definitely don't want them to break it down. And so that's found in things like dairy, soy, eggs are good sources of those. Fat is delicious. So higher fat diets tend to be more palatable than lower fat diets, although a lot of work goes into making low fat diets palatable. And also the nice thing about fat is that it has a high energy density. So whereas carbohydrates and protein are 4 kcals per gram, fat is 9. So it's 2.25 times higher than the other two. So it can get much higher calorie density. But it does have a couple things we don't love as much. It can slow gastric emptying and reduce that lower esophageal sphincter tone. So if we have animals with things like ileus or they're vomiting, maybe a high-fat diet's not the best option. It is necessary for absorbing things like fat-soluble vitamins and medications, and also to provide those essential fatty acids that are necessary for immune function, healing the skin, things like that. If you have a fat-sensitive animal, like maybe you've got some like a pet with lymphangiectasia or something like that, IBD patient, you might see something like medium chain triglycerides in those diets because those don't require the micelle and chylomicron formation in order to be absorbed. So those can be a good source of energy for those sensitive patients. And then, like we talked about before, the body has been using fat as one of its energy sources, so is accustomed to using fat. So to try to match that metabolism, a higher fat diet might be appropriate. And kind of our target for fat in the recovery state is going to be somewhere between 6 to 7.5 as a minimum grams per 100 kcal, but that really, really, really varies on the patient. And then our last macro, we've got carbohydrates. In our general critical care patients, we probably want to reduce this because they're going to be insulin resistant. They're not going to be metabolizing glucose as well. They can have hyperglycemia and actually increase CO2 production. And so feeding more carbohydrates can impair that. We want to avoid simple sugars and then also things like sucrose and lactose because, our adult animals are going to be not able to really break down that lactose. They don't have the lactase. And then cats don't really break down sucrose very well. So we're looking for more things like cereal grains or maybe starches in the food. And then fiber. Fiber is usually lumped into carbohydrates. It's one of my very favoriteest nutrients or ingredients or whatever you want to call it. Recovery diets, those tend to be low in fiber, right? Because you want them to be super highly digestible. You want them to be high calorie density. High fiber diets like weight loss diets are not going to be nearly as calorie dense. And we do have a couple of different kinds. We've got soluble and insoluble or fermentable and non-fermentable. And kind of depending on the disease state dictates what kind you want. And then vitamins. This is a super scary chart. This is also from the Small Animal Clinical Nutrition. It's actually one of my favorites because it kind of shows all of the different energy and macronutrient utilization and where all the B vitamins come into play. And so I feel like B vitamins are kind of often forgot in our critical care patients, but you need B vitamins to turn the TCA cycle. You need B vitamins to have protein synthesis. You need B vitamins basically for everything. And so don't forget your B vitamins when you're treating your critical patients. It's something you can consider adding to the IV fluids and things like that to try to help support them. And then minerals, not thought of as often probably in critical disease, but there are a couple that are going to come into play. So electrolytes are always important, right? We're always managing those in our fluids. They're going to come into play a little bit later as well. Do we have something that's sodium sensitive? Do we have renal disease? Do we need to be watching that sodium? Do we need to be watching that phosphorus? Depending on life stage, do you have a puppy that's in the hospital and you need calcium and phosphorus to be higher? And then hepatic disease, maybe you have a patient with copper storage disease and you want that to be lower. So minerals, everything's on the list, minerals too. And then lastly, water. Water is always important, it's always a nutrient of concern. General target, it depends on institution and your comfort level and species and what's going on, but about 50 to 60 mils per kg per day, kind of as a maintenance. The other way to think about that would be 1-to-1 to their DER or their MER, so their daily energy requirement like we talked about earlier. Or some people think about it in 2 to 3 times their dry matter intake. When I was a resident, I thought it was easier to do based on kind of that 50 to 60 mils per kg per day. But remembering cats tend to be more fluid sensitive, so be a little more careful with them. Canned foods or more liquidy diets that are about 80% water tend to be about 1 kcal per mil. And so you can kind of calculate how much water is coming from the food. And depending on what's going on, let's say you've got an NG tube in or an E tube in for maybe one of your long-term renal patients and you want to provide enteral water to these patients because their gut's working. There's really no reason necessarily like they're otherwise able to go home except that they have this high water requirement. You can use the tube to give water. And so you can say, okay, I want this animal to have 60 mils per kg per day. I'm getting 40 mils per kg per day, which you'd have to do the math from the diet. Well, now maybe they only need to get 20 mils per kg per day of water because they're getting enough this part of it from the diet. And then things also like flushing the tube, right? So you're flushing the tube after feeding, maybe you're flushing the tube after giving medications. So feeding tubes for water can be super, super helpful. And if they can drink, we should let them. If you're really, really worried about how much they are getting, then you can always measure it. So you can measure how much you're putting in, measure how much they've left, and that way you can see how much they're drinking. If they're messy, that's probably harder. I suppose maybe you could put like a pee pad underneath and like weigh back the pee pad, but there are options. And then non-nutrient nutritional factors, I feel like kind of get left behind sometimes. But things like calorie density, so how much can they handle, food texture, food temperature, how often do you want to feed them? So maybe that hepatic encephalopathy dog, that little shunty Yorkie or something like that, you want to feed every couple of hours instead of every 12 hours, right? Because you want to dilute out that protein dose for them. Or position during feeding. Maybe you have a dog that needs a Bailey chair. So these are all things you want to think about when you're coming up with your nutritional support plan. All right, so now we want to create a nutritional support plan. So we want them to be eating, and this is kind of a pictorial that shows what are all the things that control the appetite. So food factors, environment factors, hormones within the body. These are all super, super important. I've got the reference here. It's out of JAVMA in 2017 from Lily Johnson and Lisa Freeman, if you guys want to go and read more about it. But I thought this was a very, very nice figure that I may have stole from one of Dr. Ruggiero's talks. And then what are your patient's preferences, right? So you've got this cat or dog in the hospital. You're trying to get it to eat. What does it want to eat? So the black cat is Cinder. Cinder's my sister's cat. She only likes kibble. She only likes crunchies. Will not touch canned food. Won't do it. Connor, that's my boy in the middle. If he's getting a stew, he'll only eat the liquid part. He doesn't like the more solid parts, but he'll eat a pate. Norman is my bonus cat. Norman will steal anything that you have left unattended, including things like pizza, lettuce, chicken tenders, lattes, anything. So he's probably one that you could offer anything to and he might eat, but the other two are gonna be like, So considering what your animal, what their preferences are, is gonna be integral to actually trying to get them to eat in the hospital, and animals are different. And these are 3 cats in my life that are all totally different. And we know, with some research at Hills, dogs and cats have unique tastes and texture preferences. And so cats actually like crunchier, they want to be clean, and they like shapes. So those triangles or like other little shapes. And then dogs, they actually like softer kibbles. They want it to be a little bit chewier, and they actually like a bigger kibble. And so there's different things that go into formulating those kinds of diets to try to entice the animals to eat and improve their eating experience. And then I mentioned it with the chart earlier, but what's the hospital environment like? So when are you doing treatments, right? Is someone in there all the time doing treatments and the cat is scared and it doesn't want to eat? That's something to consider. Are dogs housed close to cats? Is the cat afraid of a dog? Probably less likely that the dog is afraid of a cat, but it's possible. How often are procedures happening? Are people in and out of there? Are they being taken away for procedures? Are they being anesthetized? Are you having rounds through the ICU? Are there emergencies in the ICU? Are people doing discharges all hours of the day? Do they only want to eat at night? Is the lighting bad? Airflow, all of these things can go into play. So these are all things to think about when coming up with a support plan in the hospital. And then Dr. Viduva mentioned this earlier when she was talking about the OnCare studies. So I stole this from some of our OnCare materials, but this is our eating enthusiasm emoji scale. And I think this is really great for critical care patients because it gives you kind of a feeling of, yeah, you can write down how much the animal ate. And I always encourage people to write down how much they're offering and how much the animal's eating. That like check plus tells us nothing except that maybe the food was put there. But then having something like this tells us, okay, so I offered this pate, the cat didn't really like it, and then I offered a stew, and maybe it was higher up on the enthusiasm scale. And so we're more likely, so then we know, okay, well, it liked this food. Can we get something that it likes more? Can we pick something similar? Are they improving in their appetite? And then just to kind of piggyback on the OnCare, because it's formulated for pets with cancer, but I think it really is also a great critical care diet. It tastes really, really good. We have a lot of science to support, these animals wanting to eat it. It's complete and balanced, whereas a lot of or at least AD is considered a supplemental or intermittent feeding. It's not really intended for long-term feeding. But this is a complete and balanced diet. AD is a wonderful, wonderful diet. We'll talk a little bit about it more in a second. It's highly digestible, so those animals are not being able to break down things as easily. It does have those omega-3 fatty acids in there, which help with inflammation. Those essential amino acids we talked about. Also, L-carnitine help us metabolize fat, support lean muscle. And then we do have our active biome technology, or that fiber technology, those prebiotic fibers included to help support the gut microbiome, try to help with some diarrhea and things like that. And then this is just a couple videos. The first one is a typical kibble. This is dog kibble. And so you can see it's a crunchier kibble. And then the OnCare, this is kind of those preferences that we were talking about before. It should be playing. There it goes. Is a much softer kibble. So to try to target those canine preferences. And actually, it's kind of funny because when I picked up a bag of the OnCare, I don't know if you when you pick up the food, you can kind of feel the texture through the food or through the bag. When I picked up the OnCare, it felt a lot smoother in the bag, which I thought was very, very cool. And so as someone who's relatively new to Hills but has always been a fan, I really, really appreciated that technology and that care when formulating this diet. And so I've got a little bit more on that in a minute, but also how much do we feed, right? So now we've picked out a diet, maybe we've picked out what does the animal like, how much are we actually going to feed them? So we would say probably, or you would think maybe, okay, so this animal hasn't eaten in a while, it's skinny, it needs to gain some weight, so let's feed it a lot of food. Probably not. In the critical care state, we're going to usually target RER as kind of our final, at least while they're in the hospital, and then as they're recovering, work to maybe getting them up to DER. But all of that's going to depend on where they started. So how long have they not been eating for? What do we think their stomach volume is like? What kind of disease do they have? What kind of risk level? So that goes back to that chart I showed before. And a lot of times, we're going to be starting them maybe they haven't eaten for a week, or maybe they ate yesterday, but they're on a ventilator now, and they've got a super high risk of not keeping everything down. So maybe we're going to start them at 25% of their RER or 33% of their RER, and then volume tolerance is going to be something to consider as well. And so this is just kind of more with the words as opposed to a pictorial form. But there's a couple of different ways to calculate RER. I think most of us are most familiar with the 70 times the body weight in kgs raised to the 0.75. You can also do this 30 times body weight plus 70, but this really only works for those smaller animals and not even our super small animals. So I prefer the first predictive equation. And then we used to say, like I said before, that we wanted to feed more, but we actually want to target that RER and avoid overfeeding because we can have complications such as GI issues, liver issues that increase CO2 production. Is not going to be ideal. And then if we've got underweight, normal weight animals, target current body weight. If we have overweight animals, I think it kind of depends on the animal and what's going on. You can target their current body weight, or maybe if we're starting to get volumes or protein levels or something like that are getting too high, maybe we can start looking at targeting their ideal weight. But it's very case by case. And again, that re-evaluating the case as you go. So what if they can't or won't eat? So that's when we start getting into those enteral-assisted feeding methods. If we can, use it or lose it. If you can't, then you can look at parenteral-assisted feeding. This is just a nice chart that talks about how long you can use these for, how large they tend to be, risks of complications. So, like we said before, was mentioned before, the NG tubes, are relatively easy to place. They're relatively inexpensive. You don't need full anesthesia. The esophagostomy, gastrostomy, and jejunostomy tubes do require anesthesia. Some of them can be left in for longer, like those E tubes and G tubes, but a J tube is really going to be more of an in-hospital thing. Those are kind of cool because they can bypass the stomach, and so that bypass the duodenum, so that post-duodenal feeding, maybe if we've got a really, really bad pancreatitis, but the more recent research would suggest that you can actually feed them as long as you're selecting an appropriate diet in the stomach, and they can do just as well. So I haven't We had a couple of J by G or JV, like via G tubes when I was a resident, but they weren't super, super common. And it was usually for those patients that they had to resect a large portion of the stomach or something and wanted to let that heal or rest a little bit before they pulled it back and then started using the G tube. And then liquid diets. So back in the day, we had clinic care. As we know, that's no longer on the market. But there are a couple of other options now. So there's powdered forms, which that's really something that we can use for bolus feeding. It wouldn't really be appropriate for a CRI in a tube, right, because it can settle out. We've got some human liquid diets, but the risk there is they're formulated for people, so people don't have that same arginine and taurine requirement that dogs and cats do. So that might be something if you're using a human diet that you might have to supplement on top or not use at all. The Parative and this Vivanex that are on here, the Parative is actually a hydrolyzed protein diet, which is really, really nice, and it's relatively low in fat. The Vivanex is elemental and very, very low in fat. And then Jevity is one of my favorites because it's a higher fiber and super high calorie dense diet. And then we also have the veterinary formulated diets as well. And so these can all be options that you can use for your patients depending on what's going on and who the patient is. And then canned foods. So we've got our critical care pâtés like our AD that are formulated to meet the needs of these critical care patients. They're high protein, high fat, lower in carbohydrates. They're highly digestible. We've got these goodies like L-carnitine and the branched chain amino acids, and also things like antioxidants, and they can be mixed up or maybe a little bit of water added depending on the food to go easily down an E tube or a G tube. And then there's some other pâtés that you could use depending on what's going on with the animal. So I did a lot of mix and matching with canned foods and liquid diets to try to get a nutrient profile, a calorie density, a slurry that I liked for the tube. But you're gonna have to use a blender. And I would always recommend testing it out. So have a tube that you use. Like if you're always putting 14 Frenches in, have a 14 French available that you can try to put these diets down to make sure that they're gonna go down nicely. They're not gonna get clogged. They're gonna come out of the fenestrations and how much you need to flush with. And so I did a lot of blending and putting food combinations down tubes and my hands smelled like dog food. It was fun. But we also have, so the nice thing about the OnCare, so the stew, or the OnCare, sorry, OnCare is the European version, is that you can actually blend these stews up to go down a feeding tube as well, which I think is really, really cool. So you can blend the foods for about 30 seconds, give it a stir, and then blend for another minute. And you get a consistency that you can see it's nice and runny, very liquidy, has a calorie density close to 1. And they're gonna pull it up here in this syringe. I believe this is a 12 cc syringe. And you can see that it just comes out very, very nicely. Nice liquid consistency, something you can use. So I like this because not only can you use it in a tube, now you've got a couple different ways, right? You've got a liquid diet that you can put down, a blended diet that you can put down a tube. You've got a liquidy food that is a different texture that maybe your animal will like and maybe they can lap it up. And you have a stew that's another texture and you can send home with the animal. And then you can also, depending, you can ask the owners to get a blender, and this is something you could use long-term in a feeding tube as well. So now that your patient's getting nutrition, there's a couple things we want to watch for. So we want to always monitor this patient, right? So more than every patient every day, especially if they're in the hospital, it's going to be at every check. So body weight, probably daily. Maybe it's an animal that you want to weigh more often. You're worried about fluid overload, something like that. Body condition, MMI. Our CBC Chem UA, fluid status is super important. How much are they eating? So like I said before, the Check Plus doesn't really tell us anything. So if there's any way you can get a scale in the hospital, or maybe your owners can use a scale, especially if they're doing something like a feeding tube where they can weigh how much food is going in, weigh how much food comes out, and then you know exactly how much your patient is getting, what % of RER, are they getting their DER, things like that, and you have much more quantitative solid evidence to say, how well they're doing in that way. Urination and defecation, those are super important. Do we have something like diarrhea that we want to address? With liquid diets, they don't tend to have as much fiber, so maybe we need to try to work on getting some fiber in there. Maybe we need to pick a higher fiber diet or a lower fiber diet if we think that not being able to digest their food is the problem, so maybe we want to pick something more digestible. And then tolerance to the assisted feeding. So do we have volume issues? Are we giving let's say they got 100 mils of food over the however many minutes it took to feed, and in an hour they're vomiting. Well, maybe they couldn't tolerate that volume. Maybe they couldn't tolerate the nutrient format or whatever, the profile. And so we want to look at that and record that and reevaluate it every feeding. And then refeeding syndrome. So these animals haven't eaten maybe in a week. They're not going to be accustomed to getting those nutrients. They're not going to be getting as much insulin, right? Because they're in a catabolic state rather than an anabolic state. And so now we're getting insulin. We're pushing that glucose into the cell. We're trapping that potassium, right? So we talked about, giving insulin to try to treat the hyperkalemia in the blocked cats. Well, this is similar, right? We're now getting insulin produced by the animal because of the food that's going to push that potassium into the cells. We also get hypomagnesemia, hypophosphatemia. And so you can see things like muscle issues with the hypomagnesemia, red blood cell lysis with the hypophosphatemia, also energy issues. Hypophosphatemia, you can have GI issues as well. And you can also have thiamine deficiency. And so all of this is not great for our patients. So we want to try to prevent this. And I don't know, so when you think hypokalemia, hypomagnesemia, hypophosphatemia, what kind of disease, management are those usually associated with that you're monitoring in the hospital? So like a DKA, right? Because we're getting those animals that we're giving insulin to and we're pushing that glucose into the cells and we're seeing a similar complications and similar things that we're monitoring for in the chemistry. And so I like to put that in people's heads just because that's something that people are more familiar with and they can think back to about what you're looking for and how you're managing it. So to treat that, we're going to stop feeding to start. We're going to correct those electrolyte imbalances, look for any contributing factors. So do we have dextrose in the fluids maybe that's contributing to this refeeding syndrome? Is something else going on as well? Do we have a too high of a feeding rate? Do we just not like the profile of the food for this animal? And once we've got those electrolytes corrected, the animal's doing okay, and we think we're ready to start refeeding to try to prevent this happening again, we either want to start really, really slow. So maybe they were getting like 75% RER. Maybe let's back them down to 25% and then slowly get them back up. We want to lower that carbohydrate content, right? Because the carbohydrates are going to be the biggest factor for that insulin release. And then really, really aggressive monitoring. And you can do the lowering the carbohydrates and lowering the percent that you're feeding. It really just depends on what's going on. Because let's say you have to have low protein and low fat, you might not be able to get a lower carbohydrate, right? Because there's only 3 nutrients you can get energy from. And so, really bringing that back and slowly increasing as tolerated by your patient. And it's not just the animals that have been starving on the street for 2 weeks. There was a neuro case that we had that hadn't eaten for, maybe 4 or 5 days. It was a dog. And after 2 days of feeding, actually had refeeding syndrome in the hospital from its NG tube. So it's not just your typical patients, it's everybody that we have to look out for. And then GI intolerance. So I kind of mentioned before, vomiting, maybe we want to decrease the feeding volume, decrease the fat content, try to prevent the ileus or that lower esophageal tone being reduced. And then medications, we might need to add some. So things like Serenia or ondansetron or metoclopramide, something like that, a prokinetic. Or maybe we need to remove or reduce some. So things like our opioids that are going to contribute to the ileus and the nausea potentially. So just kind of balancing what you are giving the patient and what the patient needs. Diarrhea, like I said before, maybe we need to increase the digestibility to increase the absorption so that we don't have all of those nutrients going to the colon, or maybe we need to add fiber to try to bulk up that diet and soak up the water and feed those bugs. And then ileus, again, may need to adjust, give some prokinetics, reduce some pain medication. Maybe you want to trickle feed, usually with an NG tube or an E-tube. We want to bolus feed these animals, but not every animal is tolerant. And so trickle feeding might be a way to get around that if you have an NG tube, or reducing the fat and fiber content, because fiber is another one of those things that's going to slow gastric emptying. And then the last one I have is, if you've got that NG tube in the stomach and you've put it in there because you're really worried about ileus or volume and you really want to know what's in there, and you're pulling all of this fluid off, that can actually have some negative consequences as well. So what I like to recommend is that you pull off the fluid, you measure how much you pulled off in the pH. So if it's a low pH, it's probably stomach acid. If it's a higher pH, it's probably more like food. But return of that fluid, I know it seems strange, but return 10 mils per kg to the patient, because otherwise it's kind of like having an upper GI obstruction where you're taking all of that stomach fluid and removing it. And so it's not getting then absorbed by the rest of the GI tract. And so you get this hypochloridemic metabolic alkalosis, which is going to not help with the patient's stability and healing as well. So to try to avoid that, we want to give some of that stomach fluid back and prevent that as an issue. And with that, I'm done. And this is Biggie, and this is Biggie's teethers, because he likes to show them when he wants things. But thank you for listening.